All right, welcome everyone. You're here today for the Minnesota Public Health Association special oral health webinar. And this is Getting to Yes, consensus-led structured state advocacy efforts to advance Medicaid dental services. A reminder, we're recording the meeting. Please feel free to use the chat, and you can also rename yourself. And we start every MPHA meeting with our ancestral land statement. We ask that you take a moment to honor and acknowledge that we are on the ancestral homelands of the Dakota and Anishinaabe. Indigenous people have a long-standing history and connection to the land since time immemorial and are the original stewards of lands and waters. Many American Indians were forcibly exiled from their lands because of aggressive and persistent settler colonialism and US governmental policies, but they persevered. We make this acknowledgement to honor the Dakota and Anishinaabe people, ancestors and descendants, as well as the land itself. All right, I am so pleased that we've got such a great audience for our oral health webinar today. I'd like to turn it over to Deb Jacoby, who's the Policy Director of Appletree Dental, and she will go ahead and introduce our speakers.
Thank you. And John, if you'd bring up the slides, that would be great. Good afternoon, everyone. It is so great to be here, and can't say how happy I am that this series is happening through the efforts of MPHA, and some of you may have attended the conference in the spring at which Jess Flotterud from Appletree and Dr. Lubov-Slashcheva, also from Appletree, kicked off this series. And John, if you'd go to the next slide, that would be great. Kicked off this series. So today it's my honor to introduce you to Dr. Sheila Riggs, who in addition to being the chair of the Department of Primary Dental Care at the University of Minnesota School of Dentistry, has been an incredible convener of people and efforts around oral health. Previously chaired the Dental Services Advisory Committee for the Department of Human Services, and has done a tremendous amount, as you'll hear about today, with the Oral Health Safety Net. And also Dr. John Pournoor, who is the CEO of Government Analytica, which is his retirement gig, having worked previously as the global government relations lead for 3M in 40 countries around the world, helping with their public policy efforts. So the next slide, please, John. So cannot thank MPHA enough, and Jess Flotterud and Dr. Slashcheva for kicking off an oral health conversation. Today is Getting to Yes about stakeholder advocacy applicable to oral health, and I think you'll learn a little bit about our challenges in that area as well as our successes. Then in October, we'll have another great session led by Jess that will have people who are working to have medical and dental integrated and to really have an age-friendly oral health system. So under the theme of oral health is about overall health. And in December, we'll take a little turn towards research. And I think you'll find it very interesting because it will be not only about learning from the data, but also about engaging the public. So patient-reported outcomes and engaging in that. So there will be more advertisements about what's happening with that. For now, I will just say thank you for listening in about oral health. I hope we can build more and more bridges between your organizations and ours. And I do realize that I failed to say my little plug about my organization, which is Appletree Dental, a nonprofit critical access dental organization coming up soon on 40 years in Minnesota, where we have regional centers and then mobile programs that go out and provide care to everyone from Head Start children to institutionalized elders and long-term care facilities. So we are very active in the policy space. And with that, it is my pleasure to ask Mary to put up a poll question, and I will be turning this over to Dr. Riggs, and then she to Dr. Pournoor. So our question is, are your clients facing oral health issues? So we'll have about a minute for that to occur.
Great. Hello, everyone. Thank you for voting and thank you for your interest. Sheila Riggs here. We're gonna just spend a little bit more time and get a few more people to vote. This is what we believe, that so many people are facing oral health issues, but it's not typically part of the community health needs assessment questions, survey questions. And so this poll is kind of proving my premise correct. Let's see. How about Mary? 10 more seconds and we'll move to my slide. I think the answer is clear. A lot of so many of you are your clients are facing oral health issues. So I think you can share the results now, Mary. Or however it works, these poll questions on Zoom. It's still on my screen.
Yeah, I think everyone should be able to see the results.
Good. So I wanted to kick this off by just saying I came to the group of dental safety net clinics with a roadmap that I had read by Kotter, K-O-T-T-E-R, about whatever change you're trying to make. There, believe it or not, are tried and true 8 steps to take. And I wanted to empower you today with this kind of roadmap, but it really sets up nicely what Dr. John Pournoor will show as the ultimate public value advocacy roadmap playbook. It's actually like a whole playbook. So I'll start with this. To drive any transformational change, or really any change, you need to establish a sense of urgency, form that guiding coalition, create a vision, communicate the vision, empower others to act. Hopefully you get some plan and create some short-term wins, which keeps the energy flowing, consolidate those improvements, and to keep producing more change, and then institutionalize what you achieved. Well, we did this in the Get to Yes group of about 15 safety net clinics, public health, dental public health leaders, and academia. So we established that sense of urgency. DHS was going to end a very critical funding source for keeping our safety net clinics open. And it's called CAD, or Critical Access Dental dollars. So that really built a burning platform. So we formed the powerful coalition of all the nodes of safety net clinics who had their own lobbyists and were trying to do some things kind of in their own kind of circle, and which wasn't achieving what needed to be done. So we brought them all together into this guiding coalition. We met weekly on Zoom, silver lining of COVID. We collectively created a vision, and you'll learn a lot about the structured advocacy playbook for from John the rest of this time. We communicated the vision. We've created a public value white paper, only 500 words, but all of us agreed with every single word that had been put on there, which was really the key to all this, that consensus. So then we also empowered others to act by holding stakeholder meetings with payers and non-dental organizations, maybe some that you are representing today. And the first short-term win was a big one. The Minnesota Dental Association and their power were joined signed on to our public value white paper. We kept consolidating improvements, working with legislators, DHS, and in June of 2021, in a bipartisan way, we got a tremendous win. It's what our asks were in our white paper, which was to double the reimbursement rate. We were 49th in the nation for dental reimbursement, and we got that. We got a real big addition to the benefit package so that all of us could treat periodontal disease or gum disease. And we got some transparency issues with the payers. And it was just a wonderful victory. Not much passed in June of 2021. We kind of forget that with so much passing in 2023. And so then we've been implementing the new law. We've actually repeated it twice. We did it in 21 and we did it in 23 with advocacy efforts around increasing capacity, where we got a really great win, and working on workforce shortage. So this roadmap, no matter how big or small change is, can be replicated by all of you. As I turn it over to John Pournoor, I'd ask Mary to put up our next poll question.
And I'm going to take a little privilege and unmute just to say that as people are taking the poll, that what Dr. Riggs describes was huge for the dental community, in the sense that this is the issues had been known for a long time, but the solutions never got the traction. So the process that we went through with Dr. Riggs's leadership made all the difference. There was nothing in that package, and it was a historic package that had not been attempted to address before. So just needed to say that.
Thank you, thank you. And what today's theme is, it's replicable. Yes, we are talking about oral health, but really for any of the interests that you care for, this roadmap and the playbook, and you know, you can reach out to John. I know he'd love to help your organization also. He's been just the game changer for the oral health community, to have his professional wisdom brought to the issue here in Minnesota. So I'm going to.
Well, thank you so much. I think I'm going to go ahead and start my section here. First of all, I'm so pleased to see so many people interested in the topic. We all build our political infrastructure in the states and in the nation based on taxation with representation. So this is an element of representation. I think that our public health leaders, all of you, may have an interest to communicate to those who dispense our taxes in the form of improvement and investments in the public health system, especially in those areas where there are gaps. I think we have an opportunity to highlight those. I want to begin actually with a little bit of a public health perspective, rather than how you put a playbook together to be able to do this effectively. If you look at historically at the evolution of healthcare systems around the world, most countries go through 3 phases of transformation. First, they try to offer basic health services to as many people as possible. This typically is immunization, pre and postnatal care, etc. Those types of things are being offered. And as the offerings increase, the costs rise. And the second phase for many countries is cost containment, to try to keep improving access while maintaining some level of cost control for budgetary predictability. And then some countries have moved on to a third phase in an effort to create cost control. The patients are disempowered. And so phase 3 is quite often a phase of patient empowerment, where you can you have some degree of say or choice in what we do. If you look at the public health system in the US, if you look at on the medical side, much of the country in the US is covered either by private or public insurance in some form, and the coverage is for preventative and acute incidents. So we're moving into, or we are in some segments, in a phase 3 or a mature phase from that public health transformation. But if you switch over to oral care or mental health and other types of care, you can see in oral care, most of the population is not covered by public insurance. Only emergency care is covered. And we're still in the early phases of trying to make oral health inclusive. So if you look at the map of the US, which I'm going to put up on the next slide, you can see sort of for those that are covered, especially by public insurance, some states have no adult dental benefits, some have only emergency, and other states have some measures of non-emergency adult dental benefits. And sort of this is the landscape today in the US. So of course, our focus is our state of Minnesota. And the question is, how do we bring this message that oral health needs as much focus as other areas that we're investing in the spectrum of public health? And that is the story of putting this advocacy playbook together. What I've done is I'm going to describe to you in layman's terms what these steps are, how to go about it. I will verbally share with you some examples of how this can be done. And my hope is that during the Q&A, we would be able to answer some of your questions, or if you have topics that you're interested in, you'd like to see more funding for research, for applications, for interventions, for community efforts. These are all areas where an advocacy playbook would be very effective. So the process of putting an advocacy playbook has a prerequisite. You need a coalition of individuals that are willing to do the work and have some political capital in being able to stand up and communicate public value messages. And Dr. Riggs just shared with you how that coalition was formed. So when the legislature or the executive branch looks to see who is asking, they can see a broad spectrum, a big swath of those who are experts or have a critical voice in this area, have banded together and in unison are requesting and asking for the change. So coalition building and having convening power is a critical prerequisite before the playbook becomes activated. A playbook with a group that doesn't have any degree of alignment is not necessarily a very practical process. I'm just going to quickly share with you what the steps are, and I'm going to walk you through the steps and show you how we implemented those steps based on the subject matter expertise that existed in this coalition, capturing the collective wisdom of that group and being able to then translate that into public value to communicate it to those who are either legislating or making decisions on these types of issues. You have to do some research, of course, to begin with. You need to know what the scope of the problem is, what the prevalence of the problem is, what the impact is. And those numbers are always good to have handy when you put your public value story together. Based on that data, we have to stand up and show that our ask isn't merely to satisfy the needs of our members in the coalition, but the ask has some greater good, has some public value. And if those public values, those requests, those asks that we have are also aligned with government's own natural priorities, in this case, it would be state government, of course, then you have sort of a winning combination where you're not pushing water uphill, but when you're making an ask and showing that it relates to one of the key priorities or more of institutional priorities that the government has, then you have that connection is really critical and important. and makes evangelism of your cause that much easier. Ultimately, when you create your messages and content, you have to deliver it to someone. And so developing a list of stakeholders, both influencers and decision makers, become important. Oftentimes, what I've observed is that this communication tends to be purely verbal. I can't tell you how powerful it is to write it down and communicate it, because when you write things down, you control the message entirely. And that control of the message is critical because your statements are not paraphrased as they're passed along from one person to the next, and the integrity of your message is maintained. White papers are critical to basically demonstrate the public value, back it up with some data, and enable you to clearly crystallize your asks and lay them out. Generally, steps 1, 2, and 3 and 4 are done prior to the engagement itself. That's your prep material, and then the engagement begins with the legislature, with members of the executive branch who are eager to hear what is it that they can do to improve the system. They rely on this kind of feedback, and the goal always is to move as many people into in favor positions when it comes to your proposal. So let me begin by walking you through some of these in a bit more detail. Research is a very critical part of the process. Of course, just like you can go to the clinical literature and gather information about the subject of interest to you, today governments put out a lot of content that can be the baseline for understanding what the public health strategies of the government is, what short and long-term goals they have, what gaps they have. These are all published quite frequently in the form of reports and other kinds of communication that would be important to have access to. I would say that the language of many of these reports tend to be more clinical in nature, and part of the process of doing research is trying to identify who is authoring these, who's a big voice behind some of these topics or issues, what is the vocabulary or language of expressing these things, and can we borrow some of that content to be able to amplify the message that we're trying to communicate. If the data and the priorities align, I think the goal ultimately is to use intelligence gathering and information gathering to be really well informed about the public health dialogue in the public health policy circles to be able to then communicate effectively. Ultimately, clinical language has to be translated into public value language. And this research enables us to figure out how to do that effectively and well. And once you receive the slides, you'll see links to all of these for more detail if you're interested in going to those pages and educating yourself about how to do this. But for now, I'm just going to speak about these at a very high level. Reading some of this content will enable you to understand what has public value. For instance, today in the Governor Walz's priorities, children loom very prominent. And so if you are making asks and a portion of the impact of what you're requesting would be to children, it would be good to highlight that, because the priorities of the government today is to put a disproportionate amount of emphasis in making sure our state is the best place to raise kids and have families. And so that alignment in public value is quite important. But unless you understand the language of the priorities and the investments that are being made, that does not become apparent. So creating a public value statement that says this is the impact to society, this is the greater good that will come out of this investment becomes really important. And if you have enough analytical data, and for all of you who have a background in public health, you know how to take prevalence of disease, overall cost of care, etc., and be able to weave, for instance, a health economic story behind the public value. If we're able to qualitatively explain the public value, but also quantitatively put data behind it and demonstrate it, then we have sort of a winning combination to be able to convince the policymakers to take a deeper look at the issues we're trying to communicate with them. One of the things I want to mention is that public value may have some absolute perspectives that we can look at it, but quite often public value is in the eye of the beholder. So the people we're communicating with, what background they come from, what kinds of positions they typically hold, etc., informs us how they perceive public value. And sort of as we identify our influencers and decision makers, we have to sort of make sure our statements of public value are general and broad interest across these audiences. So public value proposition development is a critical step in the process of developing an advocacy effort, and that comes from the research that you have done. If you look at oral health, the state of Minnesota has an oral health plan. You can find all 50 states' oral health plan. There is a national oral health status report and plan published by the Surgeon General quite frequently in collaboration with NIH and others. And of course, World Health Organization has a global oral health plan and status report. So there are a variety of different plans, and this is the kind of research that will enable you to understand what those priorities are for the topic of interest to you. I think it's important to be able to zoom in to what's happening in Minnesota, zoom out to see United States, and zoom further out to be able to see the global perspective as well. There are links on all of these pages, so if you're interested in digging deeper into any of these concepts and reports, you'll be able to do that once the slides are distributed to you. We generally create stakeholder maps as part of trying to just create an inventory of individuals who are either influencers or decision makers in the topic that we're interested in. As you can imagine, the executive branch receives a set of priorities and the budget from the legislature, and their job really is to execute that as best as they possibly can during the fiscal year. In Minnesota, we have a biennial fiscal year for which we approve our budget. The policy-making branch of government, our legislature, is another group whose members we have to profile and put in a stakeholder map. And of course, anyone that is not in the executive or legislative branch, that's what in sort of the jargon of what we call structured advocacy, we call pressure groups. It can be media, it can be associations, it can be professional organizations, it can be for-profit and non-profit entities. Anyone who has a voice or a say on a topic but is non-governmental tends to be seen as a pressure group. Now, I want to make sure I talk about this division, because what we typically do is the columns of the table that you see here is the stakeholder map for that I described, the executive branch, legislative, and pressure groups. The individuals on this map are either in favor of your position, neutral to your position, or against your position. I think we are having yet another question that we wanted to ask you at this point in time as to if you were to join would you join a pressure group, a group that is going to advocate on a specific topic or issue? Would you be interested in lending your voice and your support, your wisdom and knowledge to that group? We're keen to see how you would respond to that. I think as the data is collecting, and you can see it on the screen, I'm going to describe this table a little bit more. Generally, my experience of 30 plus years doing advocacy, and I did a great deal of that for about 8 years when I was part of 3M Healthcare. So I especially understand healthcare, ASTO, SHE. These organizations are very familiar to me because I was the consumer of a lot of content they produced, and we interacted with them heavily. My observation through having created stakeholder maps for many different programs is that quite often members of the executive and legislative branch tend to be in the neutral zone of this 3x3 matrix. Ironically, they're neutral not because they have studied the subject in great depth and have chosen to be neutral. They're neutral because they really don't know the details, or they don't understand the severity of the gaps that exist, and they are hungry for content. Imagine the legislature in the state of Minnesota, in either the House or the Senate. Each legislature has to vote on every single bill that comes in front of them. And as you can imagine, there's a wide range of bills on a variety of different topics, and no one legislature is a subject matter expert on those types of topics. They rely on others to be educated. And of course, advocacy is a form of education, especially when we put data behind it. Through research, we're able to not only promote a concept, but also prove the gaps that exist. So it's a key message I want you to take away here is that many of the folks that ultimately we want to communicate to tend to be in the neutral part of this, the neutral band of this particular table. So the goal of advocacy is actually, any kind of advocacy is actually threefold. One, you want to amplify the voice of those who are in favor of your proposal. And there are 3 or 4 true tried and tested strategies to be able to do that kind of amplification. Strategy number 2, you want to move as many neutrals to the in favor position as you possibly can. So you grow your chorus of those who are in favor and are able to stand up and back you up on the topics that you're interested in. And of course, you need to know who may be against your position, so you have a fair, responsible, and data-driven rebuttal to any challenge that they may bring forward. Again, my observation is that the game really is mostly around educating the neutrals, and that's why white papers and other kinds of communication becomes really important. So what is often called a campaign may be to take a pressure group, and I have sort of tried to show this with arrows. Take, let's say, one of the associations that has some subject matter expertise, bring them in contact with a neutral member of the legislature to, through that conversation, be able to convince them and move them into the in favor position. This is what we call basically a mini campaign or effort. So when we engage with the legislature, we always are trying to be of service to them. We're trying to educate and communicate, and also show the impact of what is happening to them, their district, and the state, of course, as a whole. So white papers are a critical part, in my opinion, of trying to communicate effectively with the influencers and decision makers on your stakeholder map. When we leave the advocacy to the stream of consciousness that may come out of someone's mouth when they're in a meeting with an influencer or a decision maker, we're basically playing to the game in a very loose manner. Legislatures and the executive branch members appreciate thoughtful, reflective content that can be brought forward to them so they can see how the community feels about a particular subject and learn from it. I would say that when we write the white papers, we want to make sure there are a few things we keep in mind. First of all, the white papers always have to be very short. My recommendation is about 500 words or less. Writing with brevity is far more difficult than having, unlimited amount of pages to describe a story. But quite often, as you can imagine, members of the executive branch and the legislative branch are pressed for time. And brevity, but with clarity and decisive communication is a really important part of the entire process. What we want to do in the white paper is typically three things. One, we want to demonstrate the accomplishments that have been garnered so far, the good work that has been done, and we want to call that out. I think it's always best to communicate by showing what has been done effectively before we talk about what needs to happen and what gaps exist. The second part of a white paper is a focus on gaps, on bridging those gaps. That's where data becomes really important to show where the gaps are and be able to not just qualitatively describe them, but quantitatively express them. And the third and last part of the white paper is a rousing call to action. I always recommend a series of asks from very simple and basic, where there is general agreement that something can be done, all the way to something that challenging that may require a great deal of alignment with a lot of different stakeholders that may need to be at the table to be able to say yes to big asks that are there. So many of our legislative and executive branch requests fall into that category. I think someone's microphone is on and shuffling of paper and stuff is part of the background noise. If you could mute your microphone, certainly appreciate it.
I think it is Lynn Fear.
Thank you. So as you can see, the first 4 steps is all about getting ready, and the conversation hasn't even begun. Step 5 is when we engage. So a lot of preparation, deep thinking, acknowledgement of who may be sympathetic to your cause, creating those stakeholder maps to communicate effectively before you schedule those engagements. Engagements become a lot easier when you're armed with something to be able to carry forward to these individuals, like a white paper, by having very clear messages. Usually engagements with members of the executive or legislative branch tend to be fairly brief, 15 to 20 minutes maximum. If they're interested, the meeting may run longer. But at a minimum, you really need to be able to tell your story from beginning to end and leave behind something in that 15 or 20 minute period. And so that's why we can communicate certainly by meeting one-on-one. We can communicate by sending letters as part of advocacy. But my recommendation is that as you engage, you want to make it as personal to them as possible. If they're representing a district, you may want to show what the oral health situation in that district may be, because they may not know that many people may not receiving the care they need. That would be an epiphany for them to learn that is something they can have an influence on. So there are a number of tools for stakeholder engagement, meeting preps, etc., that we have developed, and those are the kinds of guides that we use to try to come up with our key messages, key offers, and key asks. In the case of the advocacy that Dr. Riggs mentioned, 3 white papers were created, 1 for the previous legislative session and 2 for this legislative session. And as you can see, branding is really important. Consistency is really important. Having real pictures of real people in real situations is really important. We want to tug at the sort of heart and mind of each individual legislature to see these as real asks impacting real people. And so there is, I encourage you to click on those links, download those papers and read them to see what the anatomy of a good public value advocacy white paper is and how it can empower you to leave a very strong impression behind when you connect with your influencers and decision makers. Constituent letters are really important. As you heard, the Get to Yes Coalition and its and other organizations like Minnesota Safety Net Oral Health Alliance, they basically represent lots of clinics all across the state. It's highly likely that clinics exist in the districts of representatives or senators in the state legislature. It is important to communicate to them and not only have a generic white paper that shows what the gaps in the entire state is, but you can really localize that and show what the gap is for them. This is one I created for the group, and it basically goes into the state's databases and looks to see in a representative's district how many people are on public insurance, and of that fraction, how many may be having one dental visit a year and how many don't. And so there's public health data that we can take and impose that on or lay that on top of a political map, for instance, House or Senate district maps, and be able to make statements about constituents of each person in the House or Senate to be able to show them for their district, for the people they represent, what the impact of these programs are. But the anatomy of what you need in a good constituent letter is sort of laid out here, and we wanted to make sure you have an example of what not just a general white paper, but a very specific communication to an influencer or decision maker may look like. And so the goal at the end of the day is to be able to get as many people to side with you in seeing the value of what you're asking. And so as you see, there's a structure, there's a cadence that you can follow. There's unique content you can create. There's simple maps like stakeholder maps you can put together to be able to do that. So just to summarize, you can pick your topic and decide exactly what some of those topics may be. And I think we have a final question about what some of the topics of interest to you may be, which I think we're gonna, as you volunteer and share that information, we're gonna put that in the chat so people see what are some of those topics of interest. I'd like to finish by just going very quickly through, in 1 minute, through, this is a summary of what I said, but using reverse psychology. So top 10 ways to lose a public policy campaign request that you're trying to make. You do not have a good information network. You rely on one external person or source. That's why research is so important. You react to what policymakers do rather than be proactive and look ahead to see what can be offered that meets their priorities and their expectations. To speak with a clinical language versus a political language is one of those gaps we have to bridge. That's item number 3. We need to know what the legislative and executive branch priorities are, because it's those priorities that they're going to be pursuing. And if you can create alignment with those priorities, you are ahead. Create a coalition, as Dr. Riggs mentioned, and gave you a roadmap on how to do that. Jumping the political pecking order. We don't want to activate advocacy on someone and where we have not communicated with people that they report to, or people that may be connected to them in the political circles. We want to make sure all stakeholders hear the same message. You can ask for support, but reciprocity means that you also volunteer support, especially to your sister pressure group organizations that you may be wanting to band together to advocate for a particular topic. You have a great meeting with a policymaker, but they don't hear anything from you. It's dead silent. Communicating even once every few weeks, once every couple of months. So there's a constant a reminder that you were there, that this is a topic of interest becomes really important. Understanding cultural difference because of politics, geography, and any number of other defining feature becomes very important. And also, I believe many policymakers, especially in the executive and the legislative branch, not only want the big ideas, but they want to know what is the practical implementation steps. So detail becomes really important. And you have to understand how to read their detail, like the language in a bill or budget lines that need to be understood. With that said, I'm going to stop here and hand that back to Deb for question and answer, and I'll stop sharing my screen so we can all see each other.
Super. Thank you so much, John, and thank you, Dr. Riggs, for laying all of that out for us. And I am going to encourage people to do what Mark has done, and we'll ask him to unmute in a minute to ask his question or make his comment. But please, the chat is a little quiet right now, so please light it up with all of your questions and comments. So with that, Mark? Mary, will Mark be able to unmute himself?
Yes, Mark, if you're there, feel free to unmute yourself.
In the meantime, to get us started, I will ask a question that could go to both of you, both of our presenters. Using our oral health experience, were there any lessons or any pearls that you would share out? John has given us the process, but in the actual experience of it, in the 2021 and 2023 legislative sessions, any little pearls that you would like to remark upon?
Well, I'll just start. You know, I think all of us probably on this call, and myself included, for 25 years, always thought I was kind of doing things right by maybe building relationships with a handful of legislators and just kind of counting on those people, those relationships to achieve success. And the big pearl here is, no, you actually have to, you know, put your coalition together and use the playbook to make it happen. Because in the case of oral health, for 10 years, we had just tried to do it kind of the old-fashioned way and got nowhere. And it was really by bringing everyone together and using that white paper as the agreed upon language and ask, and then having the discipline to understand who was in supportive and who was neutral, is what got us, you know, a big success. So I know success in 2023 kind of maybe came easy to some of us just because there was so much money, but I think in the long run, you know, using these evidence-based ways forward, the roadmap about the 8 steps to leading change, but more importantly, the playbook around advocacy.
Yeah, you know, I would echo the same sentiment that Dr. Riggs expressed. I think a decade ago, the kind of data we're talking about that would enable us to build our case was not as readily available. The digital footprint of this kind of content was really not there. Many legislatures around the country were not putting their conversations, their bills, their hearings, were not accessible to us. Many of those things So what we're talking about here, being data-driven and process-driven, has become so much easier just simply in the last decade. Just simply by the transformation of government and the digitization of that content and access to us. So I think there is a way to get all of that and be able to build the story that needs to be built. But as you can see, the tools are not very complicated. Having a 3x3 table to put names in of individuals you want to communicate with is not a big task. You do research on a variety of different things. I'm sure all of you do. Doing research is not a complicated thing for any of you. But I think people don't realize that it can all be put together to tell a coherent and convincing story with political and cultural literacy to an audience of those who are trying to do good in the executive branch and in the legislative branch.
You know, I would also add, don't forget about maybe pre-law students or Humphrey students who are just searching for some kind of project to learn things real life, and that particularly that research part, that searching for what's publicly available, they could really be a powerful teammate that you forget to go looking for. But they are out there and can really do some wonderful legwork, and it's a win-win for them.
Lovely. Yeah. This is oral health specific, but for me, I keep coming back to the fact that none of the asks were new, but they were structured in public value language with the evidence, with compelling points that resonated with people. And on a lighter hearted note, that the asks were to be ordered from a super easy thing all the way to the thing that it would take several years for us to achieve. They all went through that first year. I don't know if that was a backlog of bringing the right solutions together in the right way, but it was successful. And now we have a comment, and again, I'm going to encourage anyone that would like to, we have a couple, anyone that would like to come off mute to do that themselves. But Linda, thank you for posting that you're working with adults with fetal alcohol syndrome issues, autism, some IDD things, and they don't feel dental pain, who do not feel dental pain gradually, but instead the night before an emergency root canal or whatever. How can we alert the PCAs and workers to be more sensitive, observant, and keep a calendar for extra cleanings and so on? So it sounds like you are being an advocate for clients who have great needs, and how can we do that? And feel free, Linda, if you would like to come off to say that yourself, but otherwise, yeah, there we go.
Sure. No, hi there. Can you hear me okay?
Yep.
Yes.
Okay, thank you so much. I'm not in the public health field. You know, I'm not a public health nurse or researcher. I'm an adoptive parent of a 37-year-old with fetal alcohol syndrome. And then now I'm on some advisories with other state committees and commissions. I've just witnessed it over and over. The pain is when I have a sore tooth, it's gradually building up. I have warning, I have 3 to 4 weeks. I have time to let my dentist know. Think about the money. In the case of extractions only being offered to people with severe special needs, and that can happen pretty young if they're not getting cleaned regularly, they're going to start to have caved in faces just because we don't fund it. We extract only, we don't cap, we don't root canal. My son's grandmother, my mother, spent $5,000 one year on 3 root canals for my son because there was no coverage in Medicaid. So anyway, that's just like one little story, but I do think some of the clients and consumers ourselves and our families should be at these tables at all times, really have decision-making roles with you. And so I guess I'm here to volunteer.
So, Linda, thank you. The DHS Dental Advisory Services Advisory is looking for public members. So if you or anyone in your circles would want to serve as the public member, for the Dental Services Advisory Committee, DSAC. That would be great. I also make a little plug that are at the School of Dentistry. I chair the Department of Primary Dental Care, and at the dental school, we have moved our special healthcare needs clinic into Moose Tower. And so that's where you can call to get access for at the School of Dentistry. And I had a third point, but I forgot it.
Well, those were great points.
Oh,
And
I know
Mary-
what it is. I know what it is. We got the Medicaid benefit really expanded in 23. So it
Mhm.
does cover root canals for first molars, starting in January. Is that right, Deb?
I think that's right. And we're also, part of our efforts were to create a better dental in the home network so that someone does not need to go to the emergency department when it gets to that, where there'll be many front doors to a dental home. So we're working on that as well. And thank you very much for being willing and interested. And Mary, thank you for mentioning that you can see this on some of the work that MPHA is doing around tobacco and using the stakeholder playbook. So with that, I'm going to hope that everyone will come back together on a webinar here with MPHA in October to talk about integrated age-friendly oral health systems, and again in December to talk about advances and opportunities in oral health research that will benefit your work as well, I'm sure. So with that, please join me in thanking.
Oh, yeah, but we need to go to Mary. Mary wanted to talk about future
Oh,
events.
yes, thank you. But first, just join me in thanking Dr. Riggs and Dr. Pournoor.
Yes, a round of applause for Dr. Riggs and Pournoor and Deb for all of your help as well. And also thank you to Jessica Flatterud, who's one of our outgoing MPHA board members who's worked really hard to get oral health into the public health space for our association. Just a couple reminders. I'm going to, before I let you go and finish the rest of your Tuesday here. So a reminder, if you are not already an MPHA member, please join us. We would love to have you. We have a variety of membership levels and scholarships are also available. And then we hope that we see you at several of our upcoming events. So you can find these on our website at mpha.net. We've got some really fantastic things coming up in August. The fall schedule, is being planned for our events right now. We've got our Health Equity Committee meeting next week on the 17th. A special policymaker training, people-centered advocacy, understanding roles and maximizing relationships. That'll be a great one to attend if you can. And our Policy and Advocacy Committee meets coming up next on September 6th as well. So we hope we see you back at MPHA. Your comments and suggestions are always welcome. And thank you again to our presenters today.
Thank you.
Thank you so much.